can you start
So
your...
is everybody back with a good lunch?
Yeah, we are back here. I'm Ramesh Dagubati. Good afternoon, Atul and Praveer. We have a good panel. Ravindra Rao
Hello.
from Jaipur, India. Dr. Viegas from Colombia. Dr.
Yes.
Rivero from
Hi, Ravindra.
Brazil. And Dr. Akobian from Russia here. So, hi, Atul.
Hi, everybody. And so we'll try our best to keep you awake. I'm sure this lovely lunch you had should not take its toll. So this is another interesting case we have, and Praveer and I have been discussing it. This is a 39-year-old male. You want to show the slides, and I can show you what we did. He came to us, and now we have 2-3 different strategies, and then we'll take the opinion of the panel. So if you can come to the current angiogram, the first shot we have taken today. First shot, right. So can you show today's live angio? Right. Can you all see this?
Yeah, we can.
So what we have done today is we have wired both the obtuse marginal and the circumflex. We have taken a 7 French guiding catheter. Now there are 2-3 different options for us. One option is that you dilate both of them. Just stay there, don't go forward. So we wired both of them. So one option is that we pre-dilate, prepare the bed. Praveer is suggesting that we dilate and then do a cutting for both these arteries, because there's a lot of plaque burden and we are ultimately likely to shift plaque from one artery to the other. Then either do a V stenting. So a V stenting, because there is hardly any plaque in the circumflex proximal to the bifurcation. The second option that we have is that we have a special bifurcation stent by Meril. And there is for those who are not aware about this stent, we will describe to you, let's say the side branch is 2.5 and the main artery is 3.0. So one of the stents we consider would be a 3.0 to 2.5 side branch stent. The middle portion of the stent is devoid of struts. So once you prepare your branches, then you will deploy the stent first in the side branch and do a pot after this. And here in our case, how this stent will break up is, there will be a 10 millimeter in the proximal main vessel. There will be a 3 millimeter for the bifurcation area, and there will be a 6 more millimeter into the side branch. So unfortunately, in our case, the side branch is longer than 6 millimeters. So we may have to deploy another normal stent into the side branch beyond the bifurcation stent branch segment. And after this part is treated, then we will withdraw the wire from the side branch and go cannulate the main branch. One of the main branch earlier wires will be trapped outside the stent. So after this, we will go and do a culotte deployment of a longer stent for the main branch, because we see it's a long plaque. Once you have done a culotte deployment, we have already pulled out the jailed wire. We will use that to again go and cross into the side branch and end up with a kissing balloon. So this is a second way of doing this case, which is a little more complex. It took me a longer time to describe. And then Praveer was suggesting that we can also do our regular T-stent or a tap technique for this bifurcation.
Yeah,
so what does the panel comment on these 3 strategies which we are describing?
Okay. Dr. Viegas, we'll start from that end.
I have a doubt about the LAD myth.
Yeah. So the question is about LAD. Did you do FFR of the LAD or anything?
Yeah. Yes. So
we can't hear you
it
clearly.
Like a 50% stenosis. So we have not. Can you correct the audio, please? Is it clearer?
Yeah. We can barely hear you.
We felt that this. Okay. So the audio. Okay, 1, 2, 3. Can you hear better?
We can hear you. Go ahead.
All right. So the LED on angiography did not look more than 40–50%. So at this moment, we are not planning to intubate this vessel. We may decide to do it later on if required. But these are the 2 tight lesions we have addressed on this admission. And he's a young man, 39-year-old, so we are not planning to offer him a non-angioplasty option of CABG. Okay, so we can discuss the 3 strategies that I have described. And
okay, who wants to go for? I don't know. The angle is good, but who wants to go for provisional crossover stent in the room? Provisional crossover stent, about 5, 6 people, 8 people. How about dedicated bifurcation stent, but the side branch is not good, not short enough. The lesion is longer. Yeah. Right. So nobody. Dedicated bifurcation stent. One person. And how about a 2-stent technique with DK crush? There's actually DK crush is what everybody is recommending, because I think even though you said there is no plaque, Atul, I think we have to prove that by no, actually, sorry, one more thing. How many people for V-stenting? V-stenting is only one person, Atul, I think, because even I feel that you have to do an IVUS to show that there is no plaque completely in the proximal circumflex. And so most people feel that if there is disease in the 2 branches, there's also a disease in the main vessel. Is that what? Okay. So DK crush or provisional stent strategy is what maybe I would say 60% DK, 40% provisional. Surprisingly, actually, I would go provisional.
Right.
I don't know that is the OM very large enough to accommodate a 2.5 stent, and you can you do IVUS?
Yeah, it is. It looks like a 2.5. Yeah. No, we have not done any intubation in this as of now. We didn't want to start doing any even dilatation before we went live.
Do you want an IVUS first, or should we dilate? Because I think IVUS would not go in the OM.
Yeah.
Yeah. Dilate is okay.
And once we dilate it, maybe it's going to grow in size.
Yeah, if you pre-dilate and you don't have a large dissection and the flow is preserved in the branch, maybe he could do provisional, right?
Yeah. So there are 2 types of provisional, right? One is no touch technique. Don't touch the side branch at all and cross over. But then if you pre-dilate, you should think that you might cause dissection. Sorry, Atul, go ahead.
So how many say that the side branch should not be touched at all?
Except 2 people.
Main circuit.
Yes. I'm not sure.
So pehle side mein chale?
Manish says you have to treat the side branch.
So the OM is here.
How many would treat the side branch?
Yeah, that's the one.
Okay. How many will not touch the side branch? No, only 2. Okay. So majority of the people say that treat the side branch. So I think then pre-dilate
so then we
side branch.
The side branch. Huh?
May I comment?
All right.
Yes.
So we have
can do the provisional stand, and then after see how the will be the side branch, and we can do double kissing the side branch and the main vessel also.
Yeah.
Kissing balloon.
So, I mean, we'll see how big it is. It's probably a 2.5 vessel.
Which balloon are you using to pre-dilate?
6, 8. You have taken a 2 millimeter stent, 2, 12, 8 atmospheres. It's broken.
It's 10, 12.
Okay.
14.
12, 14.
Keep it.
2 or 10?
इससे length भी देख लेते हैं.
Yes,
215,
212,
212,
2 to 15 NC balloon.
Okay, so it's a little longer than that, yeah?
15.
18.
Yeah.
Whatever
This was 12 or 13 or 15?
15.
15? Okay, so this was a 2 into 15, sorry. So this is 14 atmospheres pre-dilatation. You want to see a picture, or we do a dilatation for the circ?
Yeah, just go dilate the circ. I mean, I try to save contrast in diabetic people. Then if you don't have imaging, then you can take multiple pictures.
Yeah, he's a young guy, yeah. Yeah.
And how many of you would like to have a cutting balloon after this dilatation?
Cutting balloon? Only
Before
one
10.
person. So Yeah. I don't do cutting balloon because it's very
Only one
expensive for
person.
us. I can get another stent for the same price. So
Okay.
if IVUS
because of
shows
expense.
fibrotic tissue, then I would go
If
for.
expense is not a problem.
Negative. Negative
Yeah.
nahi hai.
You mean first the IVUS?
Negative.
Yeah, I
okay.
would.
If IVUS shows it's a fibrotic lesion,
Then we can use cutting balloon.
I think we'll take an IVUS. Fine, then we'll take an IVUS.
Do you have an IVUS ready? Huh? Acha, no, they're not ready yet. They'll have to take time. So we are skipping the IVUS.
Okay. Okay.
Okay.
Come back.
15, 2015.
Go up, please.
Go up.
16,
6,
6,
8,
8.
10, 12, 13, 14, 15, 16,
Yeah.
17, 18.
This
Deplete.
is very undersized. Okay. So this we have already sized, and all right. So that's how we look after the pre-dilatation. It's barely pre-dilated with a 2 millimeter. I'm taking. Please
You
open.
see, once you dilate such lesions of bifurcation, I think there's a lot of plaque burden is there. It's always good to have good expansion of the stent if you have a cutting balloon there.
So you go with the cutting balloon now?
If you guys agree,
We have a 2.5 cutting balloon first for the side branch.
Yeah, I think go ahead.
So we can take that.
okay.
All right.
One of the
Fine.
most important things
So we
is
take a
in
2.5 cutting
live
balloon in the
case,
upper branch.
don't change your practice. If you're doing
No,
if
we,
you-
it's still good to keep you on our side.
yes, no,
Very
no.
politely nudging you on our side. Although you denied us a chance to show you a bifurcation stent.
We would have loved it actually. We would have loved to see. I was going to ask you if the side branch can
yeah,
go
that
into
would have
the
been very
bigger OM,
interesting.
but
Yeah.
it'll be too small.
Yeah, I think the
No, we have a strategy for that because we'll have to put a
Third
an extra stent in the OM beyond the side branch extension. So we still have an option. If you want, we can show you that.
right now we are just preparing the bed.
Okay. So this is a 3.0 or a
It's
And-
bulky, है ना?
2.5? 2.5.
No, it's a
2.5.
2.5 in the side branch.
So it's
You
giving
see,
a little
see the
tough time.
fibrosis?
Yeah.
After the dilatation with the balloon also it's not going.
Probably calcified.
So this is what is the fibrosis in all these lesions.
So we'll
Yeah.
take the three, put this first in the circ,
Yeah.
है ना? And see if we can soften up the
Yep.
bed.
So what
So-
we'll do now, we'll change our strategy of taking 3 down first in the...
No,
in
we'll do 2.5 first, and then है ना? We have this ready, prepared.
the okay. you can
Try and
go
put this in the circ. Yeah, coming back.
ahead. Sorry. See that? I hope I've not pulled the wire.
Yeah, let's see. No, we are still there. Okay.
So we're going with the same balloon in the main branch now.
2.5 cutting because the angle of the OM was quite rigid. है ना? And this is a stiff balloon, 2.510,
Yeah.
and it has seen some other vessels also.
So, but after that, will you get a stiffer wire in OM1 and do cutting or no cutting in OM1?
It's an all-star
no,
wire.
we do that.
Yeah.
It's a already all-star wire.
See that?
See that? How stiff is the lesion? Still, this is not even crossing the... So we have to upsize our regular balloon first. We can have a 2.5,
You're making some
2.5.
progress.
15. Yep.
No, we
We'll
need
get
to
it
have a
in.
good bed to
Yes.
send a cutting balloon. Wait.
Okay.
No, it's holding the wires.
Okay. Fine.
But
2.5.
the
See, 2.5 same mosaic NC balloon.
the OM branch, the angle is very narrow for the
Now
cutting
we should
balloon.
tell you this first,
And
otherwise
it
nothing will go.
doesn't bend.
Yes.
Yeah. So, but he
Yeah.
tried the second attempt was
It's
into
not
the
angle, it's
AV,
a
the
little
second OM.
It's a hard.
Even that
angle, I
they
think.
couldn't advance. Actually,
Yes.
how many would use
Yeah.
the
There's no
buddy
angulation
wire
there.
here? Now? Buddy wire?
let us just dilate it a bit more. And if you notice, the balloon was, when it was inflating in the OM, it was taking a shape of the plaque.
Yeah.
So that was telling us it's a really hard one to crack.
Okay.
Yeah, go up.
Go up.
1, 2, 3, 4.
5, 6,
7,
10,
8. See that angulation?
25 enter.
8, 9, 10, 11, 12. 13, 14.
Negative.
Deflate.
He's getting pain. Huh?
Yeah, he will.
Okay, take a picture. Have you dissected or?
You can take a small shot.
Okay, so this is a. Okay,
Yeah,
we are not badly dissected.
Can you advance
This again goes into the.
Let's see the wire.
So we also do
Cutting
what
balloon? We'll do
Manish
No,
has
this is
described
the
earlier.
simple plain 2.5 balloon.
So once the balloon is up, now it's unwrapped and try to advance the balloon again. If it goes in, then the cutting balloon probably will go. One person up, I think, right? Because it was to show that there is no plaque completely in the proximal circumflex.
Yes,
And so I don't know that is the OM with call the
Okay.
Coleman's IVUS.
2.5, yeah. No, we have not done it.
So now this is 2.5
Going in the main vessel.
in the main vessel.
So it looks like you also avoided the V-stenting because now you touched the proximal circumflex, right? You pre-dilated
Yeah,
the
now we decided to touch, yeah.
No, it will
Because
be,
the,
yeah.
yes, we have done that because there was the.
I agree.
That was the area where there was resistance, you know.
Yeah, we all
Yeah.
agree.
Slightly down because
Shows the angiogram.
slightly more.
Ah,
Yeah, go up.
go up, please.
6, 7, 8,
Can you show
10,
the
12,
angiogram?
14, 16, 18. Deflate. Can we have this angio on the screen? अरे नहीं, there.
Live at me. Okay, take a picture.
Some room is there now.
Yeah.
Let us try the
So
cutting
we-
again.
OM1 looks bigger now, right?
Okay.
Maybe.
Yeah.
Yeah, it will grow.
We thought
Right.
it, always we thought it was a 2.5.
And there's no other OM, so it has to be large.
Might be bigger than 2.5. But I was.
Yeah, let's see. How do we end? It's again a diabetic vessel. So this is a 2.5? All right. So we are trying the same cutting balloon once again.
No, this won't take the curve. It might go.
No.
Put
So we need an ETO, you know? He's getting pain, you know? Why?
Do you have angiosculpt?
Cutting, it's deformed hoga, kuch.
They don't, in
We might take a 2.5 angiosculpt, eh? NY. Haan.
Sculpt is more flexible.
flexible. But I like the results.
We'll
I
take
mean, I
an
haven't compared, but the results of cutting balloon I think are much better than angiosculpt. I don't know.
Angiosculpt is basically scoring balloon, it never cuts.
Never cuts. What would you use, Praveer, now?
In Brazil, we have both.
So we are calling for a
Yeah.
And we
angiosculpt.
think that angioscope, it goes, the deliverability is better, but I agree with you that the results when you can pass it's
in the
much
meantime,
better
can
than
you
the
310
endoscope.
for the other side? Let's do 310
Yes,
here.
okay.
Yep.
Hmm?
I mean, we are not able to
By the
see
time
a
we're
lot
getting the
here.
angle,
Do you
right?
see calcification on either side of the vessel on your screen?
No.
No, it's not.
No, no, no.
It's all
There's-
fibrosis.
So it's
There's
not
only
calcified.
fibrotic hard bifurcation.
That we are
lesion
thinking we are not
and a
thinking
lot of soft plaque in the main vessel. and angulated fiber optic takeoff for the OM.
Go up. Go up.
Yeah, since it's angulated takeoff and
So in
also
the meantime,
probably
we are
difficult to
procuring the
wire,
endosculpt. Yeah.
I would think in this patient
Yeah.
probably a two-stent technique is better than earlier we were
crush.
talking about because of the angulation
and
and
crush is the
takeoff.
first one.
Maybe difficult to go back.
Because of the angle, maybe a mini crush here or a T with a small protrusion is going to be a good idea as well.
So that's the resistance.
Buddy wire, buddy wire.
So there's some hidden angle which we can't say.
Guideliner?
So there's something which is
How
pushing
many
it
would
back.
full
back.
guideliner now?
No. No, it's basically the profile of this balloon is not good because it has been
You know what?
prepared again.
We
right?
should try the stent
That's
now
right.
because if you prove that the stent goes through, then it's a very good signal. Huh?
Yeah. But then we might end up
Yeah.
in the same problem as the first
We'll
patient.
try.
Under-deployed stent and a lot of
endosculpt
fibrotic
height.
tissue behind it.
Correct.
Why reverse and see?
Although the balloon has opened well. IVUS catheter है क्या? IVUS catheter कहाँ गया? लाओ ये खोल दो. Yeah.
Yeah.
Okay. All right.
I would
So
put the-
basically, we know what we are dealing with. It's not calcium or
Right,
it's
right,
fiber
we
optic,
know.
है ना? It's
Right.
So
now we are trying an.
So we are not pushing
trying
too
an
hard for an
endosculpt
IVUS,
now.
है ना? This is a bend again, and
So all start first and
let's try and treat it. So we've got an angiosculpt 2.5,
oh, I thought you tried that.
and
that
let's
still a
see how
cutting
better we can. No, that was a 3-0 cutting, है ना? That was a
Okay.
3-0 cutting.
Yeah.
So
Yeah.
this goes.
Well, this will be
Check.
cut.
हाँ.
This will be cut. This is what it is.
Further down.
पूरा cover it है.
That's good.
Okay. Go up.
1, 2. 2.5, 3. 3.5, 4. 4.5, 5. 5.5, 6. 6.5, 7. 7.5, 8.
Okay.
8.5, 9. 9.5, 10. Good enough. Deflate. Now we just cut
Push.
those.
I'll just put it back,
Yeah.
है ना?
Yeah. Just delete as it will cut. Yeah. Can I check?
Wait.
That one.
Okay. Sure.
No, ठीक है. Go
All
up.
right. Go up.
1, 2, 3, 4.
2, 4.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Deflate. For guiding under
20, 25 more.
guiding under
हाँ पीछे ले लेता हूँ.
Having pain?
Yes.
Yeah. So
We
giving
have
him
not
little
been nice
more.
to the arteries, so he will have pain.
Wait.
Dr. Agarwal,
So now we take this.
let
Yes.
me ask you a question. In your personal experience with angioscope, you can go up to higher pressures. So what is your limit?
You
18
can.
Yeah.
atmospheres in your clinical
Limit
practice?
is about 18.
Yeah, that's what we do also.
Usually 18.
That's why we're wondering. That's why I think
Negative.
Enrique is
And the
asking
cutting
how
the
come we
limit is
stopped at
further
14?
higher.
Negative करो. पूरा नहीं हो रहा.
No, approximately we did 18.
Please careful. I can
And
feel
not
it here.
28 like in the other case, right?
No. Haven't tried it. These wires have gone a little forward. हाँ.
यही करना है.
ये यहीं काटेंगे है ना? That's bifurcation. आगे तो soft है. Okay.
Go up.
Go up.
6, 7, 8,
Yes.
9, 10, 11, 12, 13, 14, 15, 16, 17, 18.